What we would like to do over the next 2 hours is take the model that we have right now and use it in a number of different examples, trying to take advantage of our breakout groups. And so what we've asked the leadership of each of those groups to do is to give 2 examples from that they came up with their discussion yesterday, and talk about where it fits in the model. Which mismatches are we talking about? And then what are the levers that it can be applied to, so we can sort of flesh out our list and understand how levers might work. And then also to begin to mention metrics that could be used to track that. Our meta purpose here is to get us as a group familiar with using the model in order to describe practical situations that have come up. This is one of those things where we are reasoning inductively. We need a number of different examples and just get comfortable with using the model, and that will help us for the next phase. So why don't I start maybe with Mary Beth? And I've asked, I think we've got slides for one of them, but most of them will be just presenting from the chairs. And I've asked each person to talk about it for about 5 minutes, and then 5 minutes for commentary from the group. So, Mary Beth?
Sure. So our group was group number 1, and our question was, who should fund health professions education? To be honest, I think that our examples went all over the place really to meet the model. Joanne was my co-lead. So our 2 examples, we had an example of generally getting students exposed to broader populations, not just your standard suburban population. And the veterinarian medicine gave an example of how they place their students in the shelters and really get the exposure to the population in the exposure in the shelters that is different than what is a general practice that might be in a suburban area. So the mismatch here is your traditional health professions education and getting them outside of the students outside of their comfort zones so that they actually see a bigger population other than their norm that they're used to. This also takes into account the idea of academic and community partnerships with employers, and even then exchange, if there was any exchange of funds to help these sites precept the students and have the students there. So the incentives there's a couple of incentives that we talked about. We used a lot of the levers talking about carrots and sticks, how we would build these partnerships. And what we talked about here is the incentive to the employers if there was any exchange of finances. There could be always incentives to the students that choose to go to the non-traditional clinical areas where they may get a stipend or some sort of funds for going to those areas. So that was the first example we used. The second example was around the public health education. John talked about some of the new things that have happened in public health. I think most people know that students need now for accreditations for the schools to have field placements. But the other piece of this is how the accreditation body came in to support this and say that we want data from you to see not only what your students are doing while they're in the academic cycles that they're in, but what happens to them when they graduate? Where are they employed when they graduate? And does it meet the population needs? So again, it's using the accreditation mechanism as a lever to move what we see as getting students into different populations. Metrics. The metrics in this case is obvious with the accreditation asking for this information. So there is actually a formal mechanism now that there's a feedback for specific metrics. I think when we think about the metrics around some of the other elements that we talked about here, which is academic community partnerships, what would that look like? And this is where I'm going to open it up to get some ideas from the group here. Thinking about what the metric is what is the proportion of students going to different populations and seeing that broadly so that not all 90% of your students are going to the traditional suburban practices for their clinical experiences, but getting them to be exposed to the full population.
So if I'm understanding it, as you're thinking that the public health example, for example, is there's graduates don't meet population needs, and that's the mismatch.
And the mismatch with the same with veterinary medicine, where not all of the practice is in suburbia, where there are shelters, where there are other populations for the students to be able to have exposure to. And I think this is universal even when it comes to some of the other.
And I thank my veterinary colleagues for talking about shelters in a very different sense than I've been thinking most of my life. So, other comments from the group? Again, we're trying to use the model, other mismatches or metrics. And two good examples of metrics, I think, in that case, in both of those cases.
So anybody from my group want to talk a little bit more about what other metrics we talked about? I don't know, John, are you here somewhere? I don't know where everybody's sitting.
Okay. So I think the next one would be the redoubtable Rob Smith.
With my excellent task focus group, we just filled in the grid. And so I've selected a couple of examples of different mismatch. Do you want me to do both in sequence? So the first mismatch is about population health needs not being met by demand. And it was in relation to the mental health needs of various populations, both internationally, where they were unable to access both psychiatry and counselling services, and domestically in terms of segments of the US population with chaotic lives or homeless or whatever. And I think it's Kathy's, but is she in the room today? Been running a programme. No, sorry, it was who was it who was running the programme on mental health first responders? Was it Wendy? And so that's the challenge. And why is there a mismatch using the model? Okay, so there's an inability to pay for those professional services. So you could try and solve that. But what this has solved instead is to go to a service and workforce redesign solution. And it comes to Malcolm's point, which is the supply side needs to talk to the provision side to link these things together, a bit like we were talking with the clinical pharmacist yesterday. And they've come up with the idea of a mental health first responder who can be trained. So this is lay people and community workers and others, trained in some basic counselling therapy, but not to registered counsellor level. I'm paraphrasing here, guys, so if I've got it wrong, jump in. And potentially also some kind of navigation to services if there's a kind of a crisis. And why is that attractive? Well, because these are voluntary community people, and therefore that's a cheaper response. It's a service, it's not a full service. Let's not pretend these are psychiatrists or counsellors, but definitely in that space, something is better than nothing. And only at that point do you then come to say, okay, so what's the supply route for that? So the interconnectivity of this model just takes you down the stream. So there's a program to give people those skills and confidence, and then you get into HPE funding. Well, HPE funding of this skill, and it's broadly philanthropic. And then we had a discussion about, is it philanthropic because of it's those communities, overseas development aid, in disadvantaged parts of your community. And then we kind of had a discussion, but would it ever be mainstream? Is this actually a good model, to supplement and complement, traditional professional services, counselling, etc. So, metrics. What struck me was, as we went through a number of the examples, is and it's Malcolm's point to a degree, keep it simple. So the first metrics is, what do we need to observe the mismatch? So this is a model that says, let's observe mismatch. So is there a health shortage? Is there something that says, either in terms of health outcomes or, activity per this group of, something that tells you that there's something going on between need and demand. I then think there's something like metrics that observe the impact of the policy or the solution. So how would you count this workforce, for instance, if it was as simple as saying there are X thousand of them in Malawi or whatever? You know, it's a measure, it's a start. But lots of systems don't have ways of capturing, especially non-traditional workforces. We're pretty good at counting nurses and doctors and things, because we've got registration and mechanisms for doing it. So it was in that kind of territory. Shall I move on to the second one, or do we want to pause and...
We go to this, actually, thoughts on the first one. Mental health, first responders as an example, and then Patricia.
I'm wondering if we could build on, and I don't know enough about it. I just keep coming back to the police and the gaps that we have there. And I know that within the law enforcement larger community, there is training for people when there are hostages, you know, the hostage negotiators and all of those. And I'm just wondering if it could be thought about coupled with that kind of training, you know, and not necessarily call it mental health, but more of a crisis management concept, because really that's really what we're talking about from a first responder.
De-escalation training or whatever, yeah.
Yeah, and just maybe reframing it, because I think the other piece that when I talk about in the population health, the reason it's such a problem is nobody wants to admit it exists. Because if we call it mental health, and that means there's something wrong with you 9 times out of 10 people think you can't fix. And so.
And your comment actually triggered another one with me, is that using the example of mental health is another window on the gap between population health needs and perceived needs, except it goes in the opposite direction than we're usually worried about perceived needs being higher than actual needs. But in mental health, because of the taboos we have around mental health, it's actually lower. So it's another way of this model is helpful for analyzing both other kinds of non-traditional health workers and another way of looking at an information gap. Patricia?
One of the things that's interesting about this model is that it's a train-the-trainer model. So it's not just that you're actually training the layperson to be to intervene for simple health issues. You're actually training individuals who can then go into the community and spread this way of intervening. And they're very clear to say that they're not training health professionals. They're training them to do simple things that can assist the community.
Which also brings up another issue that we've not systematically addressed, although it's a part of kind of the educational interventions, which is the organization and pedagogy of the interventions. We think that there are pedagogies, for example, active group learning, that greatly improve the performance of underrepresented minorities, which may improve supply in some way. And an economic question, again, I'm not one of those dismal scientists. That's really not fair. But is that actually material enough? Is it a significant enough effect to include in this? I think there's a lot of academics in the room who would think, yes, it is. Of course, what we do is new curricula, new ways of organizing what we do, but it's a question.
Shall I do my second one then?
Do the second one.
Okay, so the reason I selected this is this kind of sense, and Malcolm talked about it earlier, that this model can be used as a kind of a tool or a guide, something that basically helps you to highlight the cause and effect of a problem in a kind of structured way. And in so doing, not only would it help you to think what interventions might we make, but it also helps to kill myths. And this is a kill myths suggestion. So the proposition, I shouldn't really point at it, the proposition was that there is a demand and supply, a classic demand and supply mismatch, and a oversupply mismatch in terms of pharmacy. And that's the contention. And this is where this gets really simple, because the second step of this story is John, my colleague from down there, saying, no, there's not. There is no unemployed pharmacy. Indeed, there is continuing underemployment and unemployment and shortage in a number of areas. So what struck me about that is we have a tool that allows you to have a proposition and then explore it. Now, ideally, you then explore it with metrics. So what is the metrics we have in the demand to supply gap in terms of under or over provision. So in our world, it's a lot of employed stuff. So vacancies is the shortage. Are there posts that are funded but not met? That's your shortage measure. Oversupply is really hard, really hard. And that's to a degree why kind of waste on the other side is more prevalent, because if everybody's satisfied, great. Spotting the underemployed or the unemployed person is much harder than saying, I've got a post and can't fill it. And the I've got a post and can't fill it leads to a lot more noise than the underemployment. So it was a simple example in some ways because it stops there, in terms of the levers, but it does talk about metrics that help you use it and the kind of thing it can be used for.
And it strikes me as very similar to what Joanne presented yesterday with respect to nursing. And so that kind of question is true differently in different countries and with different professions. And the challenge of how do you figure out what underemployment is with data. Yeah, good. Other comments or questions?
Warren, so I'm now thinking about Rob's example here and Joanne's about sort of you could have enough overall supply but have specific geographic shortages. And so the other thing this model does is enable us to identify and diagnose those specific geographic shortages or specialty imbalances, but then also identify the levers that you would then say, okay, if we have enough overall supply, how do we actually then create incentives for practice in those other areas or create, a way? So we have to also take it one step farther, Rob, to the policy levers and say, then we're going to have different types of policy levers to address these sub shortages. Yeah.
Which is arguably where medicine is right now.
Exactly. And nursing.
The same sort of way. Yeah.
So I totally agree. And there is care in use of the model, isn't there? Because you could have a national perspective that obscures local shortage or oversupply. Right. Conversely, and we see this a lot, which is you get local shortage that is then, that doesn't describe the national position, but is used in a policy sense to describe the national position.
Particularly if it's in Boston, I notice.
Particularly if it's in Britain. I was just, in terms of the policy levers, so I was just looking at your Government of Accountability report from 2015 about healthcare planning, because we had exactly the same report from our National Audit Office. And I know that the kind of myth around local shortage is then played out in a national report. So, and they didn't have access to this, to be able to split the diagnosis down into its component causes and to take a national local lens, with the danger that you get some kind of fairly powerful policy levers like government reports and select committees saying stuff that is largely true but not accurately true, specifically true. So, it's that kind of area that I think this model could be quite powerful.
Excellent. What? Yeah.
I think Aaron's comment about the maldistribution is universally true for all health professions. And I think the comment about what would change that is very important because we've got a long history of that circumstance without anything necessarily that has been effective. So I think that is a large part of the dynamic and would support specific development for interventions in that area, and seems like that's worthy of its own conference altogether.
And what our model has done, just to belabor this point, is to frame it from an overall supply demand to a different question, which is a regional or other kinds of imbalances.
That is so much better. Thank you. And I think I will say, coming from, if you haven't met me already, I run the government relations shop at ACOM, which represents the nation's colleges of osteopathic medicine. And I'm thinking about messaging. You talked a lot about messaging. And I think it's really timely to look at the issue that Aaron just mentioned. Because, Congress, policymakers, they hear about shortages all the time. There's a shortage, whether you're looking at primary care shortages in my field, whether you're looking at specialty shortages. But then they don't know what to do with that because they don't have the specific information in terms of geographic shortages. and so forth. And so I think it's really timely. Congress has been looking at this stuff for quite some time, but there's always this kind of challenge when you bring these things forward. They say, okay, there's a shortage, and then what? What do you want us to do with that information? Because it's very broad. What do we do here in terms of looking at maldistribution? And so it's really timely, I think, now to come out and really look at the nuts and bolts of what that all means. So.
And it also points to when we talk about actors, the importance of disaggregating the actors, which governmental policies are doing it, and understanding which unit of analysis we're working at. When we go on to the next one, and that would be Kathleen.
Okay. Well, thank you.
This is on financial justification for socially accountable health profession education.
Thank you. I didn't have to say it myself because it is a mouthful. And I want to thank the great group we had. And I was privileged to be paired with Erin, who's so articulate, and it's amazing. So I was up last night watching the report on Matthew, and I put a slide up here because it blew into basically where I grew up, in the Space Coast of Florida. But then I was looking at this picture a little longer, and I thought, gee, I hope this presentation isn't just a lot of hot air. So I apologize for the bad joke, but it is day 2, and I'm the last presenter, I think. So what we did, and Megan, what we did in our group was, before we started talking about ways of changing and creating levers and so forth, and finding where the mismatches are, we wanted really to talk about and set the context of what is socially accountable health professions education. And so what I did was I took a very broad, wide-ranging conversation and tried to put it into a few points. And of course my group is here, and they're going to comment on it, hopefully. But what we wanted to say before we talk about the mismatches and the levers and the metrics is that the socially accountable health professions education is health and wellness focused, that it's necessarily inclusive of a broad array of professionals. And by professionals, we also really did talk about people who may not be considered in the usual lexicon as professionals. This actually includes home family members who are caring for their family members, and they need to know the types of medicines, generic versus brand, and so forth, things like that. The leadership and institutional mission for socially determinants of health really need to be aligned for anything that we do to be successful. And I think Malcolm mentioned that this morning, and I think it's been brought up on a number of comments. The institutional mission is very critical in instituting any change, is my belief. That it's going to be, we have to find the places and the people who are ready, and leadership is key in that. That whatever services we want to put in place really need to be integrated across a community, and by community we mean whoever is in need, and that assessment really needs to be organic from the community, based on the community's needs and preferences. So I don't really like the term community because I don't really think it means anything, and it's often to me a little bit derogatory. It means poor people or those people or geographic or whatever. So I think community can really be whatever we want it to be, depending on where we're identifying the mismatch. Educational venues, whatever we're describing, really need to be responsive to both the student competencies development. In other words, where we're creating change and where we're creating, I use clinical education, but remember we have law clinics, so they don't have patients. Clinical means real life. It can be in the home, it can be in the schools, it can be in the ICUs. But the educational venues really need to be aligned with whatever competencies that we're asking our learners to have, to go forward with. And that implies that we actually need faculty and mentors and role models in those settings, which harkens back to what we've talked about in terms of need of faculty development. Public funding, and this was a point that was made a couple different ways. Public funding really implies public service. Now, whether that means payback in years of service, whether that means accepting publicly supported insurance, such as Medicare and Medicaid, we don't know. But what we're basically saying is if you've had the opportunity as an individual and as a community to receive public funding that's given to us by taxpayers and others in the public, then that it necessarily implies, if we want to be socially accountable in terms of our health profession education, that it implies that there is, I don't want to say quid pro quo, but there is an obligation. And then finally, the final point around social accountability is that financial planning, and we could actually, maybe economic planning, I actually like that, Erin. The economic planning really has to be data-driven. Clinical, and again, that doesn't necessarily have to mean medical. It can mean, other types of social outcomes that are measurable. That the planning really has to be data-driven, and any planning has to necessarily include how are we going to figure out what we did. So sort of outcomes-oriented, really in the very beginning of setting up the plan. So, Megan, next slide. Okay, so we came up with a lot of different things, and this is just kind of where I ended up with it. So the first mismatch that we wanted to point out would be here, the mismatch where graduates do not meet population needs. It's the mismatch between supply and health professions education. And basically what we're saying here is that we want to make sure that we have innovative, and again, the clinical means real life, wherever that is, innovative clinical training environments that appropriately prepare graduates for high-value care. And I heard the term high-value, I think Malcolm mentioned it quite a few times this morning. So whatever that high-value care is that the community has assessed that it needs. Examples might be a recognition that we have a high narcotic prescription rate in our particular neighborhood or community or hospital or setting. How can we treat pain syndromes that could be better addressed maybe through home-based care, more touch therapy, what we often call alternative, but I don't think it should be called alternative. We often call it complementary, but not necessarily complementary, because these services and professionals need to be integrated into our health education system. But how can we create clinical, again, in the very broad term, environments where students and learners can model integrated care in an environment like that? Another example might be creating environments where we're addressing, and hotspotters, I think everybody's familiar with the hotspotters, creating environments where we're treating and reaching out to patients who are 20% of the population and using 80% of the dollar. So we're creating higher value venues for the students and learners to learn. So that that learning might be through improved social work, improved community integration with clinical needs. It might be responsiveness to the community needs through better mental health recognition, et cetera. So that's our first one. Megan, would you put the next one in? The second one that we looked at, or we're trying to talk about, is the mismatch between population needs and demand. And what we said here was that we want, in a certain way it's similar, but it's different, create health training learning environments that support out-of-hospital, end-of-life care. And we also wanted, I didn't put it on the slide, but Miguel this morning reminded me, we're also talking about frail people care, not necessarily end-of-life care, but caring for people who have need and try to keep them out of the hospital. So it's sort of changing from expensive fee-for-service type care to creating a mechanism through out-of-hospital longitudinal continuity care that may involve a lot more caregivers than, in other words, a team-based approach than is typical. There's mechanisms already in place to pay for that through, for example, hospice covers that. And we, I didn't mention what we can measure on the first one. I'll go back to that. But what can be done with this would be to leverage annual savings based on compare to prior expenses, or you could compare to a group that wasn't getting the intervention to estimate savings. So then the metric would be the increase in number or percentage of patients who perhaps as one would be who die outside the hospital compared to previous. Of course, we're not going to prevent death probably, but at least we can ameliorate the expenses of end-of-life care. Can we go back to the prior one? And I just wanted to talk about what we could measure on that one. So that would be possibly a return on investment that that we could measure. That would be, for example, clinical outcomes would be improved, savings, for example, fewer emergency room visits, or another example is David Ash's work. Maybe many of you are familiar, who showed that obstetricians who trained in highly safe obstetrical environments during residency, that they tended to have a lower risk practice as they went out. I think he followed the obstetricians out maybe 10 years. So there's definitely a link between what the type of institutions that people train in and how they practice later. So I'll stop there, Warren. And
so what I'm hearing from your group is an emphasis on a couple different kinds of mismatch. One, graduates who don't fulfill population needs in several different ways. And then the other is this, bringing up the issue, which we've not yet talked about, of end-of-life or frail person care and the gap between what we're currently doing there and using that as a metric, perhaps to fund financing.
you hear me right, and those are just examples. I think the larger picture is that what we're saying is, in order for the social determinants to be brought forward and addressed, that these interventions need to be based on a community-aligned assessment based on need.
And one for the last segment, comment?
Yeah, I just wanted to add, I think we had a nice discussion in the group about when you think about financing, we often think about bringing resources in, and we were talking about how we can reduce the level of resources spent if we're financing the right types of education. And it's a reverse.
That's exactly what we were getting at.
The Holy Grail. Edson, for your section on identifying new sources of money to pay for health profession education.
Okay. Thanks, sorry. So first of all, thanks for the group discussion we had yesterday. Probably the summary here doesn't describe very well what we discussed, because the discussion was much broader. And also, to avoid repetition, I'm going to summarize. So the group work was identifying new source of money to pay for health professional education. And we used the UN High Commission report on health employment economic growth as a background to discuss what would be the entry points for health professional education, taking into account the influence and potential to create jobs and inclusive jobs, etc., economic multiplier, etc. So based on that perspective, we identified new funders as non-traditional government departments, like, let's say, the Ministry of Labor, Trade, and Finance, in the way they to expand the funding for health professional education. There was a discussion about service providers and employers. For instance, there was an example about hospitals. The private sector, but there are some new ideas, maybe not too new, about private sector, like social franchising. And I believe there was a topic of one of the forum meetings last year. And also there was some suggestion about manufacturers, specific on the pharma industry. And also that was mentioned already about philanthropy. You know? But philanthropy, like, as I said, take into account the perspective of jobs, look beyond only the health sector, but look how philanthropy involved in economic development, lending, microfinancing, etc. In terms of example of mismatch, we talk about the productivity, and I think that's linked to some of the discussion I had yesterday and today about the value-based care, value-based education, right? So in the sense, in many countries, we have an issue about productivity in the health sector, and that would be something identified as a current mismatch. And the other that's been mentioned are the unemployment, right? As I said, many countries have seen discussed these days. We have the issue of unemployment, even though in some places there are shortages in rural areas. So the policy levers, first, cross-sectorial dialogue. Again, coming the perspective for employment and jobs, economic growth. So you need to expand the discussion about health professional education, and that includes education sector, health sector, social protection and labor, and finance. And I think probably many of countries, even the education and health, they don't talk much. So it's this is need to expand the conversation for other sectors. And also in terms of measuring the effect, you discuss measuring effect. As you discussed yesterday, we do measure effect in the health sector, but you need to measure effect beyond the health sector. As I said again, employment, inclusiveness, etc. In terms of metrics, we discuss the number of jobs created and the multiplier effect, the economic multiplier effect of having more jobs in health, and what is the consequence of that. Again, look in the perspective of the impact on the economy as a whole. And the impact of overall productivity and the economy. In the sense, for instance, we discussed about yesterday the issue about whether the health sector absorbs productivity growth from the other sectors or not. So we need to measure this better. And there's a long discussion among economists whether the consumer price index used for the general economy applies or not in the health sector. Basically, you cannot measure the productivity in the health the same way you measure productivity in manufacturing. Specifically in the health sector, if you don't increase the quantity of service, the quality of service provided increase. Like say reduce of pain, etc. So that's not well captured in the consumer price index. And they need to measure that better. Of course, this is beyond the health professional education, but we have the effects, the outcomes of health professional education affects this. And the final point was about, say, if you want to measure the employment impact, as I said, beyond the health sector, we need to get better information about the health workforce, and that goes beyond only counting numbers of doctors, nurses, etc. But we need to get better information about education, like how many years of education, how many training they have after the in-service training, about the compensation, as we've been discussing since yesterday. Wages influence choices, but in many countries we don't have data, good data about compensation. Right? Household characteristics, family circumstances influence choices, and also about the employers. So this is a summary. I don't know if my team group wants to add something.
Wow, I'm hearing several. I mean, you've mentioned many points, but I'm hearing several kind of elaborations of our model. One is a new actor, if you will, the microfinance and other kinds of that, of local responses to local needs, and there's clearly some models. That number two, another way, a novel lever, which is dialogue. Sort of intriguingly, we haven't included that, but it's a good example around the dialogue between health and economics that we've started and helped with here today. And then a lot on how do you measure if indeed there's economic benefits of this, that you do need to measure that, and you need to have a data system in order to measure all of that, be able to do forward. But other reflections on this breakout group? Patricia.
I think indirectly, different groups have mentioned how it is we assess whether we have a shortage or not. And I think there's a connection we might want to explore between the stress work that we've been doing because, for example, I'll just use nursing as an example. We have a number of nurses that maintain their license, but they've left nursing. And just in the last year or two, I've probably met 5 physicians that left medical practice. And so, I think our models for assessing whether or not we have a shortage and where we have a shortage are not, when we've been doing it by licensure, to some extent, maybe need to be really looked at. And then the number of people that, I was thinking about the pharmacy thing that you were talking about, that those educated people are maybe using their health professions education as a lever to do something else that a normal other person might not have that background in education to have as a lever. So they're not necessarily unemployed, but they're
Or
not
Not
employed.
without social benefit.
Exactly, yeah.
Yeah. Rob?
Yeah, I think I had this discussion with Edson yesterday, which is when you get into that demand-supply gap, we're often talking about kind of new supply, but actually we should be talking about available supply. That includes the current stock. And not least, you can deploy that supply, including retaining people, treating them well, giving them satisfying jobs and engaging them in their work. But we've done a big piece on return to practice, which is how do you get people who aren't active but have the skills already? You don't need to start 5 years back. And I think we need this in the model somewhere, which is the supply to demand gap can be solved either by changing the demand, new HPE supply, or something in that supply performance kind of space. So that's certainly how this is my bread and butter stuff, because that's where we live and how we respond to this stuff.
And in the States, it goes the other way of 2008 recession. Many people's 401ks become their 101ks, and they're still in work for a while, and you modify.
Sometimes we confuse, we measure supply and we think it's employed, but there are other employment models like agencies and things. This is still a deployed resource, and yet we don't count it. In fact, we treat it pretty badly.
Yeah.
One of the things I did want to say is the interconnectivity, which is, so say you acted to reduce demand, you might mismatch shift rather than mismatch solve, because you could have just shoved it
Another dimension.
population needs.
Bjork?
I think it's really important to exactly think about this in different ways. So, for example, some of the countries that we've seen, in order to retain, to address that might be, for example, doing continued professional education may be one lever to keep people. So some governments have, in some cases it's government, it doesn't necessarily have to be government actors. Another thing is providing research opportunities for clinicians or training them as faculty at clinical sites. So there's lots of ways that sort of co-finances a better distribution of health workers that it's looking at.
Yes, indeed. Other comments? Yes, ma'am.
Well, just in response to Patricia, we do have that data on employed licensed nurses. All the boards of nursing have it, but it just makes me realize that there's probably a lot of data out there that people don't know about that this could really help with.
Good. Somebody else over here? Yeah.
So I keep thinking about how easy it is when we talk about shortages, to think about the usual suspects, so to speak. It's easier to count, to have a sense, even given the challenges, to have a sense of shortages within physicians and nurses and so forth. But we're not quite getting at the mismatch around expensive care versus prevention and the other kinds of health care providers that we should have in that space.
The gap of our discussion.
Mm-hmm.
Yeah, I think that's a really good point. Good. I think we're at end. This is exactly what we wanted. I think there's a lot of examples that have looked at different parts of our model, and I think leads us to the next questions in helpful ways. So thank you very much.